Okay, let's dive right into this explainer. Today, we're unpacking a massive, high-stakes challenge that sits squarely at the intersection of clinical care and healthcare administration. We're looking at the incredibly difficult task of distinguishing pediatric RSV from COVID-19, and we're going to tackle this from two distinct angles. First, for the parents and providers desperately seeking clinical clarity in the exam room, and second, for the medical coders who absolutely need administrative accuracy to keep the wheels of the healthcare system turning.
Here is how we'll structure our journey today. 1. The Great Respiratory Mix-Up. 2. Spotting the differences. 3. Documenting long-term impacts. 4. Cracking the diagnostic codes. And 5. Vaccines and procedure codes. Let's get into it.
Section 1. The Great Respiratory Mix-Up. A parent's panic and a coder's challenge.
So picture this. If you've ever stood over a coughing, feverish toddler in the middle of the night, frantically wondering which virus you're actually dealing with, you know it is a terrifying moment. You are definitely not alone. The reality is, the symptom overlap between these two is just so huge that even the most seasoned clinicians out there sometimes need a lab test to be absolutely 100% sure what's causing the illness.
And honestly, it's those shared symptoms that make this such a tricky puzzle. Both are highly contagious, right? Both bring on the fever, the coughing, shortness of breath, a runny nose, a sore throat, and headaches. So on the surface, a sick kid with either virus can look practically identical. It really is the ultimate diagnostic curveball. But we absolutely have to get this right, because the stakes are incredibly high, especially for our most vulnerable. Just to put this into perspective, RSV alone sends between 58,000 and 80,000 children under the age of 5 to the hospital every single year in the U.S. Infants under 6 months, premature babies, and kids with existing lung or heart diseases, they are at the absolute greatest risk for severe complications.
Section 2. Spotting the differences. Finding the clinical tell.
So what's the big clue? Well, the crucial thing for parents and clinicians to watch out for is the gastrointestinal tell. RSV rarely causes vomiting, diarrhea, or stomach pain in kids, but COVID-19? It actually often does. So if a child has that cluster of respiratory symptoms we just mentioned, plus some GI trouble, COVID-19 is way more likely to be the culprit. It's one of the absolute clearest clinical dividers we've got.
It also really helps to look at how RSV presents across different age groups, because it changes. Because RSV is a lower respiratory tract infection, it hits infants very differently. We're talking scary breathing struggles, rapid breathing, and poor feeding. But in older children, it tends to just look more like your run-of-the-mill head colds, congested nose, sneezing, a low-grade fever. And these symptoms usually pop up about 4 to 6 days after exposure.
Now, COVID-19, which spreads through respiratory droplets or contaminated surfaces, can bring its own highly unique markers. While kids are generally luckier and more likely to have mild symptoms compared to adults, they might suddenly lose their taste or smell, get a severe new headache, or even develop weird skin changes, like discolored patches on their hands and feet. Plus, complications can sometimes trigger wheezing or a harsh, barking, croup-like cough. Section 3. Documenting long-term impacts, bridging the clinic and the coding desk.
You see, the story doesn't always end when the initial infection clears up. What's super interesting and frankly a bit concerning is the lasting mark RSV can leave behind. Research actually links early life RSV to recurrent wheezing, asthma, and even reduced lung function way down the road. So this complete symptom picture absolutely must be captured in the chart to support the right ongoing care for that child's respiratory future.
The same goes for COVID-19. Kids recovering from it sometimes report lingering symptoms that just won't quit. Stuff like fatigue, trouble sleeping, difficulty concentrating, joint pain, and a persistent cough. These aren't just minor annoyances. They genuinely interfere with a kid's daily life and must be thoroughly documented.
And this brings us right to the concept of clean claims. For medical coders and providers out there, this level of detailed charting is absolutely vital. If a case isn't confirmed by a lab, like a swab, an X-ray, or a blood test, every single sign and symptom literally has to be documented to the absolute highest level of specificity. Providers and coders working together to capture this full picture, that is exactly what stands between clean, approved billing claims and frustrating denied ones. Section 4. Cracking the diagnostic codes, navigating ICD-10-CM. All right, let's get technical and start with COVID-19. For the coders tuning in, you always want to use U07.1 as the primary code for COVID-19. But if there's an associated condition, you've got to sequence that secondary condition code immediately after it. For example, pneumonia due to COVID-19 is U07.1 followed by J12.82. Acute respiratory failure, that's U07.1 followed by J96.0. Think of the primary code as the anchor and the secondary code as the paint that fills in the specific clinical picture. Now, RSV has a totally different set of rules. When you're coding for RSV, B97.4 is your primary code. For diseases classified elsewhere, meaning it's used alongside a code for the related condition it's causing, like an upper respiratory infection. But here's the catch. You cannot use B97.4 with excludes 1 conditions. Things like acute bronchiolitis due to RSV, acute bronchitis due to RSV, and RSV pneumonia, those demand their own dedicated codes, like J21.0 or J12.1.
Section 5. Vaccines and Procedure Codes, Administration Guidelines.
Let's look at RSV protection first. Eligibility for the RSV monoclonal antibody polisivimab is highly restrictive. It is explicitly tied to some very precise conditions and gestational timelines to protect the most vulnerable infants. We're talking about infants with serious underlying heart or lung conditions or premature babies born before specific gestational weeks. In stark contrast, the COVID-19 seasonal vaccine is recommended much more broadly. The CDC actually recommends it for all children 6 months and older. Why? Because even completely healthy kids without any underlying conditions whatsoever can develop severe COVID-19. That's exactly why pediatricians strongly encourage the shot. It protects healthy and immunocompromised children alike. And when it comes to actually administering those COVID-19 vaccines, coders have to navigate this rather complex matrix of ICD-10-PCS codes. What's absolutely vital to note here is that the codes vary based on 2 specific things: the dose sequence, so is it dose 1, a single dose, or a booster, and whether the vaccine was given subcutaneously or intramuscularly. You have to match both of those elements perfectly to get an accurate claim. Jumping back to RSV for a second, the CPT codes for administering the RSV monoclonal antibody have their own little quirk. The codes explicitly differentiate based on whether interaction happened. So you'd use code 96380 if counseling was provided to the family during the administration, whereas you'd use 96381 if the administration happened without any counseling. Lastly, for complete, bulletproof documentation, you can't forget these essential Z codes. Coders use Z28.310 to document an unvaccinated status for COVID-19 and Z28.311 for partially vaccinated. And hey, if a patient is simply coming into the clinic just to get a shot, you pair the correct procedure code with Z23, which basically just notes an encounter for an immunization. So as we wrap up this explainer, I want to leave you with this thought to chew on. Whether you're a frantic parent tracking a sudden stomach ache in your toddler or a coder meticulously verifying a secondary diagnosis for acute bronchitis, it is these precise, granular details that truly matter. Are you capturing the full picture? Because getting this right is exactly what keeps our most vulnerable kids safe and ensures our entire medical system runs exactly the way it should.